Take it away, Alex.
Hi, can everyone hear me okay?
Yes.
Okay, thanks. Thank you for joining me. Today I will be speaking about the involvement of the complement system in COVID-19. Next slide, please. The complement system is a proteolytic cascade that is part of the innate immune system. It acts as a first line of defense against infection to neutralize pathogens and both alert and recruit immune cells. Complement can be activated through three interrelated pathways: the classical, lectin, and alternative. And these pathways converge at the generation of a multi-protein complex that inserts itself into the cell membrane with the goal of killing the targeted cell. And infected and damaged host cells can become the target of complement, leading to organ damage when it is pathologically active. And complement has been implicated in contributing to the development, progression, and severity of COVID-19 for a variety of reasons, including direct observations of the blood and organ tissues of COVID-19 patients and in vitro studies of proteins from the SARS-CoV-2 virus. Next slide. So the objective of our study was to characterize the involvement of each pathway in the progression and severity of COVID-19, using pathway-specific markers of activation in the blood of COVID-19 patients. We also looked at the ability of someone's complement status at their time of ICU admission to predict mortality in the following 30 days. A total of 25 critically ill patients admitted to the ICU at Vancouver General Hospital were included in this study, and 25 healthy controls drawn from an existing biobank were analyzed for comparison. Concentrations of complement analytes in blood samples were estimated using commercial ELISA kits. Next slide, please. We found that the three markers from the common and alternative pathways, C5a, BA, and factor D, were strongly associated with abnormally low blood oxygen relative to the amount of inspired oxygen, which is indicative of acute lung injury and a feature of acute respiratory distress syndrome. Next slide. Complement activation persisted throughout hospitalization. In panel A, we observed that the alternative pathway remained chronically activated, well above the 95% confidence interval of the healthy controls. In panel B, we similarly saw persistent activation of the common pathway, and activation status appears to fluctuate in response to corticosteroid treatment. This is in contrast to acute phase markers of inflammation shown in panel C. For example, IL-6 tends to spike extremely high and then rapidly fall in some patients a few days prior to worsening respiratory failure or death, whereas in survivors, IL-6 tends to steadily decrease as patients recover. Next slide. So to summarize, alternative pathway activation was a prominent feature in these patients that correlated with the severity of lung injury, and complement was highly activated at admission and stayed activated throughout hospitalization. So given their persistent elevation, we found that the concentrations of the BA fragment and factor D showed utility in predicting mortality in the 30 days following ICU admission. For example, the odds of dying increased fourfold for every 1 unit increase in either BA or factor D on average in this cohort. And these values were comparable to other known risk factors such as diabetes and obesity. D-dimer, which is proposed as a robust predictor of mortality in many other cohort studies, was a poor determinant of survivorship in this cohort of critically ill patients. Complement status may therefore be more sensitive to predict death in patients who are already extremely sick, whereas other proposed markers tend to be derived from cohorts composed of people with a range of severities from mild to severe COVID. So our study serves as strong evidence in support of conducting much larger cohort studies on the involvement of complement in COVID-19 and its utility in identifying critically ill patients admitted to the ICU that are at a higher risk of dying. We're now transposing this into in vitro studies. So thank you for listening, and I would be happy to take your questions.
So thanks very much, Alex. I'm sure there are people who will have questions, but I have one for you. Have you looked at setting up any controls in other settings where you have hypoxemia to understand whether this has actually got to do with the virus, or is it the hypoxemia that's causing the alternative pathway activation?
It's unclear. Obviously, vascular inflammation is playing a huge role. We're not really sure if complement is driving the disease and contributing to the pathogenesis, or if it's a response to inflammation and then endothelial cells are being targeted by complement because they're now sensitized. So it's something that's not really clear in the literature. It would be really, really interesting for us to get samples from hypoxemic patients of other diseases. We're working on an endothelial cell-based assay to look at complement deposition and activation on cells. So I don't have a good answer for that right now.
Yeah, no, it's just one of those questions about how specific the effect is. Dr. Nee.
Yeah, so Alex, that's very nice work and interesting work. To my understand, there is no drug clearly block this complement alternative activation pathway for the COVID, right? So do you think there is a possible we could design some specific drug to stop this complement activation? But first, I would think you probably need to establish the cause and the result. Whether this mortality is a result from that alternative pathway activation, or just the instance occur after hypoxia, right? So the patient will have the hypoxia after COVID. So could you please give some comments for this?
Right now, we're doing some mechanistic studies to figure out whether or not the alternative pathway is contributing to the severity of the disease, or, like Dana suggested as well, it's something that's happening in response to hypoxemia and viral infection. So we're not sure at this point. In terms of the alternative pathway, we think it's probably a good target because of its involvement in feedback activation of the lectin and classical pathway. So if we could turn off the feedback loop, we might be able to dampen complement activation. So there are a few therapeutics in various stages of clinical trials, I believe, for the alternative pathway. But right now, people are really focused on eculizumab and ravulizumab, I believe. So there have been some case control and cohort studies showing that it's efficable. But in terms of, I think there are a few, danicopan, for instance, the factor D inhibitor might be good to try.
Yeah.
Thanks.
I actually think that John Lamberst has a clinical trial going with that, with his anti-D inhibitor. Any other questions? Well, if not, thank you very much, Alex.